Welcome, everyone. This is our conference on breast cancer and the environment and advances in detection and treatment. Tonight, we have Sumedha Ghate with us, who's a genetic counselor and medical geneticist at St. Vincent Hospital in Green Bay. So she'll be presenting on genetic counseling and hereditary cancer testing and who this may benefit. Thank you, Sumedha.
Thank you so much, Dean, and it's my pleasure to be here. And I'll just give you a little tiny bit of information. So medical geneticists are physician providers, and genetic counselors are master's level providers. I am a genetic counselor, and I work with medical geneticists, but I am not a medical geneticist. So genetic counselors are people who have usually gone and gotten their bachelor's at with a degree. Mine was in genetics at University of Madison. And then I got my master's at Sarah Lawrence College, and I've been working at St. Vincent Hospital for over 25 years. At St. Vincent Hospital, I provide genetic counseling services to lots of different people. And usually people are coming for hereditary cancer testing. They are also sometimes coming for neurogenetic testing or information, cardiovascular genetic information or testing, and really anything related to anything genetic or hereditary. We'll often sit down and talk to people about the specific conditions, and they have questions about, could this be hereditary? If it's hereditary, is there testing for it? What are the pluses and minuses of testing? And so those are the kinds of questions that we answer. I also have a part-time job at the Hemophilia Outreach Center. And as many of you may know, I did provide this presentation in person in October at the Clearwater Action Council's presentation, conference, which was Breast Cancer and the Environment, Advances in Detection and Treatment. And for those of you who have not had a chance to attend that conference, I would highly recommend that you watch some of those recordings because it was a really great conference. Thank you so much for Dean and the whole team for putting it on. It was excellent. I learned a lot. So I hope that you will find my presentation helpful. And I'm going to just let you know what the objectives for this presentation are. It's to help people identify red flags for hereditary cancer. It's to help people learn who may benefit from genetic counseling and genetic testing for hereditary cancer, and to help people understand how hereditary cancer testing results impact cancer risk management and screening recommendations, because that's really what it's all about. It's about helping people identify a hereditary condition if it's there, so that treatment can be made more effective and ideally help cancer prevention as well. So if there are any questions, if people come on later on and have any questions, you are welcome to ask. So whenever we see any information about genetic counselors in the media, often you'll see a picture, something like this, that shows a person working in a lab pipetting something. And I just want you to know that most genetic counselors are not working in a lab pipetting anything. Maybe some are, but most of us are not. And we are usually just sitting at an office and talking to people across the table, which I suppose is not as exciting, right? A picture of somebody pipetting stuff in the lab is probably more exciting. So that's why they use that picture. But really, this is what I do day to day. We help people understand and adapt to medical, psychological, and familial implications of genetic conditions. We help people interpret family and medical histories to assess the chance of disease occurrence and reoccurrence. And we provide education about inheritance, testing, medical management, prevention, research, and help provide resources. So why should people have genetic counseling before genetic testing? Most people think that genetic testing is just a lab draw, it's just a test. And why should somebody go and meet with a person about that testing in advance? The reason is because genetic testing continues to become more and more complicated and more common. And timely genetic counseling provided by individuals with expertise and experience is critical. Every day, there are errors that occur in the ordering of genetic testing, the interpretation of genetic testing, and this causes patient harm. So there's a lot of documented case series about different errors in genetic counseling, and this is just one of them. This was the fifth in the case series. So when people don't understand enough about genetic testing, it's very easy for those test results to get interpreted inaccurately and for inaccurate tests to be ordered in the first place. And when we talk about genetic testing, it makes it seem like it's just one thing, but it's not. There's hundreds of different genetic tests, and people like me who have expertise in genetic testing are trained for a long time about the use of genetic testing, and we understand the different methodologies. Most medical providers may have limited training in understanding and interpreting genetic tests. So what is genetic testing? Let's talk about two different kinds of genetic testing that are very common in the cancer arena. So when we talk about germline genetic testing or hereditary genetic testing, that's very different than tumor genomic profiling. And that is more related to testing that's done on tumors. So germline genetic testing, that is testing that's done from somebody's blood. Let's say it can also be done from a cheek swab and getting some of those cheek cells. So germline genetic testing identifies gene mutations that increase a patient's risk for a primary cancer diagnosis. So these are mutations that may be shared by family members. That testing helps us identify specific hereditary cancer condition and understand the risk for other new cancers to happen. Tumor genomic profiling is a whole different thing. Tumor genomic profiling is used to characterize mutations that are unique to the tumor, and these are called somatic mutations, things that are only present in the tumor and not something that somebody is born with. So these mutations identify pathways that may be targeted for cancer treatment. So they're two separate kinds of tests, and they're used for two separate reasons. So when somebody says genetic testing in the cancer realm, you always want to make sure, are they talking hereditary cancer testing, or are they talking somatic cancer testing that's being used for treatment reasons? So all cancers are genetic, but most cancers are not hereditary. So when we're talking about somatic mutations, like we just did in the setting of the tumor mutations, those occur in non-germline tissues, meaning tissues that are not eggs or sperm. They occur in the breast cells or the colon cells or lung. These are not inherited cancers. These are sporadic cancers. And a majority of cancer is this. This is 90 to 95% of cancer is not hereditary. It just happens because of changes that happen in our cells as we get older. And then the other type of mutations are germline mutations. Those occur in the eggs or sperm. They're present in the eggs or sperm. They are heritable. They can be passed from one generation to the next. And once inherited, that mutation is present in all cells of the body. And this type of cancer, hereditary susceptibility to developing cancer, accounts for about 5 to 10% of all cancer cases. So how often is cancer hereditary? About 5 to 10% of the time. What's the rest of cancer? Well, if we divide it out further, about 70 to 85% of cancer is sporadic, meaning that it just happens in an isolated individual or maybe one or two individuals. It's mostly linked with age because age is the biggest risk factor for getting cancer. And then about 10 to 20% of it happens when you see more than one, more than two, more than three people in a family that have cancer, but it's not related to hereditary cancer causes. So genetic testing for hereditary cancer might be normal in those families. They might not have any type of hereditary mutations, yet you tend to see cancers that are happening more often than you would expect in that family. Now, could this be related to environmental causes? Sure. So could they be a family of smokers and you're happening to see lung cancer in people who are smokers? That could be. So pretty much we want to think about hereditary cancer happens in about 5 to 10% of most types of cancer. And I'm going to go through and show you a family tree, or what we call a pedigree. And some of the symbols that I'm going to talk about, I'm showing you here. So males and females, males are square, females are circles. And then when we are talking about a specific person, we point to them with this arrow, and that person is called the proband, or the person that would be my patient, for example. Siblings are connected in this manner. And then those are the main important points that I'll point out. And let's talk about a family here. And in this case, we are going to talk about Jean. Let's just call her Jean. Jean comes in because, hang on one second. So Jean comes to a genetic counseling appointment for possible hereditary cancer testing. And I'm going to go through this family tree with you, and then you're going to think about it. Just think about whether you think this is a hereditary type of cancer. So Jean herself is 37 years old. She is cancer-free. Then she has a sister that is 42 years old, and she was diagnosed with breast cancer at age 42. Then her, Jean, so this is Jean's sister, and then Jean's father is here, and he has just some colon polyps, but he is cancer-free. And then we have Jean's paternal grandmother, and she was diagnosed with breast cancer at age 55. So just think for a minute, do you think that this breast cancer is hereditary? And I can't ask you guys right now, but I know that when we had the in-person meeting, most people who answered said that no, likely that they did not think that this family tree represented a hereditary cause of breast cancer. And my answer is that yes, this certainly could be a hereditary cancer family. And why is that? The reason for that is because we know some of the red flags for hereditary cancer, which include a younger age at cancer diagnosis than expected. So what is the age at breast cancer diagnosis most often? Most often, breast cancer happens in people when they're postmenopausal. Often it's women, and often they're postmenopausal. So if you have a woman diagnosed at a younger age, that is just one little red flag. So if a woman is diagnosed at age less than 50 or less, that qualifies for hereditary cancer testing. And that sister that we just saw, so Jean's sister, she was diagnosed with breast cancer at 42. So that qualifies for hereditary cancer testing. Now, is that necessarily going to definitely be a hereditary cancer family? We don't know. And it could very well turn out not to be, but that's enough of a red flag where you would want to make sure that that person at least understands that they have the option to go see a genetic counselor and consider genetic testing for cancer. So when we see multiple generations with cancer in the same family bloodline, that's also a red flag. If there are multiple close relatives with cancer, especially if it's cancer of the same type or a specific pattern of cancers, and a pattern of cancers, that would be all different things. And lots of times people don't necessarily know what a specific pattern is. But for example, breast and ovarian, that's a pattern. Or uterine cancer, ovarian cancer, and or colon cancer, that's a pattern. And those patterns are not always familiar to people themselves, but if a person is wondering if the pattern of cancers in their family is suggestive of a hereditary cancer condition, and should they go see a genetic counselor, they can specifically ask their primary care providers, I have a family history of such and such, and does that meet criteria for referral for genetic counseling? And that would be a good question to ask. And then the genetic counselor would assess whether or not that family met criteria for hereditary cancer testing. The presence of rare cancers and some of the above characteristics would also be a red flag. So for example, a male breast cancer, that's not a very common cancer. So that would be a red flag for hereditary cancer. But the bottom line is younger age of cancer diagnosis than expected. That's an important thing to pay attention to. So these are the guidelines that we look at every day, lots of times, and the National Comprehensive Cancer Network, or NCCN, creates guidelines that help us decide who qualifies for hereditary cancer testing and genetic counseling. So this is the big red arrow at the top. This is age 50 or less with breast cancer, and that meets criteria for referral for genetic counseling. And then there's a whole bunch of other criteria. So family history of one or more close blood relative with breast cancer who is age less than 50. So if you have one person with breast cancer age less than 50, that meets criteria. If you have a person with breast cancer at any age and they have a relative with breast cancer at age less than 50, then that also meets criteria. So I'm not going to go through all of this, but basically Jean met criteria for testing. The ideal thing would have been if her sister would have been available for testing. We would have preferred that her sister get tested first, but her sister was not available to her. Maybe she is not in touch with her sister. And so Jean was eligible, let's say, for hereditary cancer testing. So these are just some of the red flags that we went through: breast cancer age at 50 or less, colon cancer age at 50 or less, rare cancers, multiple cancers, and family history of cancers. So Jean's family history meets NCCN criteria for genetic counseling and hereditary cancer testing. Testing an affected relative is best, but Jean is not in contact. So is this testing going to be helpful to Jean, and how? Because that's the most important question, right? Just because testing is available, that doesn't mean people need to have it. It's only if it's medically beneficial to a person. So why do hereditary cancer testing? The reason is because identifying a hereditary cancer condition can lead to early cancer detection or cancer prevention. It's not only about hereditary breast and ovarian cancer, but there are 70 different hereditary cancer conditions. This is no longer just in the news, but this is a real and increasingly important piece of cancer care. So genetic counselors meet with individuals to discuss testing, risks, benefits, limitations, and implications of results. What are they going to mean, and what are we going to do about them? Genetic counselors facilitate decision-making about testing and coordinating testing. So we can utilize one of many labs. The little boxes you see on the side, those are kits that we would get. And then we make decisions about where would we send that testing. We would also be able to understand what that testing involves. So for example, the first box you see up on top, that is a lab that typically, things are changing slowly, but typically in the old days, they did not do RNA testing. Now they are, but that would be one small thing that we would consider as to, do we want to send the sample to this lab or not? And then the second box down, that lab does do RNA testing. So we have lots of reasons why we may or may not use specific labs, and we wind up using specific labs more often than other labs, and it really depends on a whole bunch of things. So the bottom line, and the reason I'm telling you this, is because it's easy to order a kit. It's easy to get somebody's blood and send it off, but you have to have the knowledge to understand what are the differences between the different labs, what are the testing methodologies, so that you can order the most accurate test for that person. So the samples can be either a blood sample or a cheek swab, and the sample is analyzed for the spelling errors or spelling mistakes in the DNA of people. We all have the same genes. So all of these genes that are listed on the left-hand column here under the word genes, these are all good genes. All of us have 2 copies of each of these genes, and they are working correctly for most of us. So we always get one of these genes. So let's say the BRCA1 gene. We get one of these genes from mom, we get the other gene from dad. And when my hands are up like this, that means the genes are working exactly right. When there's a spelling error, mistake, or mutation in the gene, then that means the gene's not working right, and that gene turns off. So if a person has a mutation in the BRCA1 gene, the first gene on the top here in this left-hand column, what does that mean? That is a good gene, remember. But if you have a mutation in that gene, then that causes an increased risk for specific cancers. Now, is it 100% risk? Does that mean that that person is going to definitely get that kind of cancer? No, it is just an increased risk. So that person would have an increased risk for developing breast cancer and ovarian cancer. Those are the main ones. And there's a small increased risk for some of the other cancers. So if we look at a different gene, so if we look at this MSH2 gene, again, it's a good gene, but when we have a mutation in it, it increases the risk for specific cancers, ovarian, colorectal, uterine, for example. So that is an example of different mutations that can be identified. So what happens? Well, maybe we send off genes, test sample, blood sample to a lab, and the lab report comes back like this. So what this means is that there was a BRCA2 mutation found. So this is the gene BRCA2, and they found a mutation or mistake in the BRCA2 gene. This bunch of letters and numbers that just pinpoints exactly where that mistake or that mutation was. So in the old days, if we think about people who had testing prior to 2013, we used to only do testing for two genes. So two genes related to breast cancer mainly. There's always exceptions, but it was usually testing for the BRCA1 and BRCA2 genes. So this was in the previous days. If we would have found this for gene, then that would have meant that we have an increased risk for somebody for a person who has this mutation. They are at increased risk for breast cancer and ovarian cancer, and a little bit higher risk for some of the other cancers as well. And here are the risk numbers. So for a person who has a BRCA2 mutation, their risk for developing breast cancer throughout their life is anywhere from 45 to 69%. So that's a pretty wide range. And the bottom line is you just have to think of it as increased risk, significant increased risk. So if that person had a first breast cancer and then that person didn't realize that it was related to a BRCA2 mutation because maybe they were never tested, then their risk for developing a second brand new breast cancer would be about 40% to 50% within 20 years, and about 20 to 30% within the next 10 years. And so this is not the risk for recurrence, not the risk for spread, but this is the risk for an actual brand new breast cancer to happen. And so this is why getting information about these mutations and genes is important for surgical decision making, because a person, if they knew that they had a very high chance for getting a brand new second cancer, might make different decisions about surgery than if they did not have one of these high risk mutations. The risk for ovarian cancer is also increased here, as you can see, with BRCA2 mutations, as is the risk for breast cancer. However, most men that have a BRCA2 mutation still will not develop male breast cancer. As you can see here, it's only 6 to 8% of those who carry that mutation would actually develop breast cancer. And then there's some other increased risks. So what do we do once we know that a person has an increased risk for developing certain kinds of cancers? Well, there's guidelines. We look at guidelines and we review them with a person. So they might choose to have increased screening. So what does that look like? Increased screening would mean that they are eligible for mammograms annually, but then also many of these people, especially if they're young, would be eligible for annual breast MRI screening, because breast MRI looks at the breast in a different way than with mammograms and has a higher detection rate for identifying early stage breast cancers, especially in dense breast tissue when mammography is much less sensitive. So we would, go through some of these guidelines, and I won't go through all of this, but we would help people understand what are the medical management implications for these cancers, and we would help them get to the right people to talk about other types of risks. So for example, what is the risk for ovarian cancer? What should we do about it? And if somebody wanted to talk to a surgeon about removing the ovaries, then we would make sure that they get to the right person, which is often a GYN oncologist. So here are some of the clinical management implications for BRCA1 and 2 mutation carriers. Some of them choose to have increased cancer screening. Some of them decide to have cancer risk reducing surgery. So that means a bilateral mastectomy or a bilateral salpingo-oophorectomy, meaning removal of the ovaries and tubes. And it also gives people the chance to inform at-risk blood relatives. So what's my job in all of this? It's to basically help people understand that when you choose the cancer screening path, what you're saying is, I understand that I might develop breast cancer or a second new breast cancer or an ovarian cancer, and I understand that risk, and I'm willing to be okay with that. And I'm hoping to catch cancer early if it's there, and hoping to catch it at an earlier stage when treatment is most effective. Some people are very comfortable doing that. Other people say that, you know what, I don't want to just keep waiting and I don't want to keep doing cancer screening. I would rather do preventive surgery so that I can not have as great of a risk for developing this kind of cancer. So it's a really personal decision that usually people wind up making with their surgeons. Okay. And we will give information to individuals to share with their families. So individuals are encouraged to share their results with their blood relatives because this has important implications for blood relatives. We usually will share a family letter that's given to patients, and they are encouraged to share that with their relatives. But these results are too often not communicated. And we don't really understand totally the reasons for this, but I think people are embarrassed. Maybe they don't want to cause stress for other people in the family. Maybe the family bonds are just not there and they feel awkward in sharing this information. But we always encourage people to share it because then they've done their job. Once they've given the relatives the information, then the relatives can look at that information and make a decision for themselves. So the goal of cancer screening is to try to catch, excuse me one second. The goal of doing hereditary cancer testing is to try to catch a cancer early. And here is an example of what happens without surgery. And there are people who carry BRCA1 mutations, and if they have only bilateral mastectomy at age 30 and no ovarian cancer surgery, well, you can just follow this graph through. Oh, sorry about that. So BRCA mutation carriers can greatly reduce their cancer risk before disease occurrence. And that's the bottom line. That's the message of this graph here, that by pursuing prophylactic surgery, people do reduce their risk drastically. But some people do not make that decision, and some people choose to go down the screening path. And as long as they understand the information and what the risk numbers are, then I think it's a personal decision. So risk perception is very unique to everybody. Individuals view of high risks or common or rare, unlikely. These words don't always mean the same things to all of us. So there's a lot of things that influence how people think about risk. And there's some people who you can say the same number. You can say the chance of such and such happening is 10%. And some people, and a person will say, oh, wow, that's very small. And other people will think that that is a very high risk number. So what are the factors that color their perception of risk? And some of the things that color people's perception of risk are their experiences with cancer. So when I have families where there's many, many generations of people who died of cancer, especially at younger ages, those people are very concerned about any higher level of cancer risk. And those will be the people who are very motivated to reduce their risk for developing cancer as much as possible. So it really depends on each person and what their experiences are with cancer. So this is a test report for somebody who had a CHEK2 gene mutation. So not all cancer genes are created equal. A lot of us know a lot about or have heard about the BRCA1 and 2 genes. And those are genes, when there's a mutation in them, they cause a pretty high risk for development of breast cancer and ovarian cancer mainly, and some other cancers. But there are other genes, and CHEK2 is one of these genes where if there's a mutation in the CHEK2 gene, if there's a moderate risk mutation, then that increases the risk significantly, but not as high as with the BRCA1 or 2 mutation. So it might increase the risk about twofold. So not all cancer genes are created equal, and the risk numbers are different for different genes. So here is the information that you would see if you looked up information about CHEK2 in the NCCN guidelines. So I often have people who have mutations in the CHEK2 gene, and this particular gene, I would review with them that the evidence is insufficient for risk-reducing mastectomy and to manage their risk as based on family history. So as you saw with the BRCA1 and BRCA2 gene mutations, a reasonable approach to reducing their risk for cancer is to do a bilateral mastectomy or to remove the ovaries. And that's based on data that it does prevent these types of cancers from happening because those are high-risk genes. And the CHEK2 gene, there's insufficient data that tells us that doing a preventive or risk reducing mastectomy is going to be beneficial. So this person would potentially opt for increased breast cancer screening, and that might be breast cancer screening with just mammography or potentially with breast MRI, depending on their own clinical history, age, and other factors. So the point of explaining to you about the CHEK2 gene is that genes are different. Some are high risk genes that cause high risk for breast cancer, and some genes cause a lower or moderate risk for breast cancer. So there are different kinds of test results that are possible. There's 3 possible test results that can happen with any genetic testing. One would be a positive result, meaning, yes, we did find a mutation, and that was the result that we showed you previously. There was that test report with the BRCA2 mutation. There was that test report with the CHEK2 mutation. Both those were positive results where we found a mutation in a gene that significantly impacted cancer risk for those people. So here is a different kind of a test result. This is a test result that identified a mutation that is not a clearly significant mutation. So there are changes in genes that are called variants of unknown significance, and those changes do not influence cancer risk significantly because we don't know enough about it. So yes, there is a change in the gene. We don't know what that means. And just because we don't know what it means does not mean it's bad. So I use this example often with my patients that I am from India. And as a person from India, if I were to send my sample to most of these labs, they're not going to have as much data from people from India as they are people who are Caucasian, likely. So it's very possible that because we don't have enough data, that my test results might come up with a bunch of different genetic changes. And if there's not enough data about those genetic changes, if the lab is not able to say that that genetic change is just normal variation, then they are going to call it a variant of unknown significance. That does not mean that I have many different abnormalities in my genes or that I'm going to have lots of different cancers or anything like that, or increased risk for different cancers. Basically, it just means that we don't have enough data about this. We're just going to put these things aside. We're not going to do anything with these results. We're not going to test relatives with these results. These are just called variants of unknown significance, or VUSs. And we will wait for more information down the road, but right now we are not going to base any medical management on these test results. So that's a very common test result we get. So here is another type of test result where this is a gene that is on many of our hereditary cancer test panels. I think it's slowly being, they probably won't have it on other test panels in the future, I'm guessing. But this particular mutation causes no increased risk for breast cancer. So if we look at that red box, it says current data do not support an increased risk of cancer over that of the general population. And it's important to understand that, but it does have implications for carrier status. So that means that if a person carries this mutation and they are together with a reproductive partner who also carries that same or a mutation also in the same gene, and their child gets 2 copies of that mutation, then that could have significant implications. But being a carrier of one mutation is not associated with increased breast cancer risk. So I put this slide in there only to highlight the fact that genetic test result interpretation is not always black and white, and it is sometimes complicated, and it's important that people who have expertise and training in genetic testing are sharing information with you if you ever decide to have hereditary cancer testing. So these are some common myths that I hear about for regarding hereditary cancer testing. They say, you know what, I already have breast cancer. Why do I need hereditary cancer testing? What difference does it make now? Well, as we discussed, the reason it makes a difference is because some of those people, not all of them, but some of those people are going to potentially have a hereditary cancer condition where they would be at an increased risk for getting a brand new cancer and not know it. And understanding and diagnosing a genetic cause of hereditary cancer makes a difference in their medical management. So here's the other things that they say. They say, I already know if I'm at high risk and I'm being screened. So maybe if a person has a family history of colon cancer and they have, let's say, a father, a grandfather, and an uncle with colon cancer, and they're being screened for colon cancer, that's great. And they're doing a good job getting screened. But if it's Lynch syndrome, and if they're being screened for colon cancer, then they're not being screened for the other cancers that go along with Lynch syndrome. So that could be super important, especially for women who have Lynch syndrome. They have an increased risk for uterine cancer and ovarian cancer. So it's really important for people to have a genetic diagnosis of a hereditary cancer if it exists. And insurance doesn't cover testing. So that is a very common myth. Majority of people that I see have insurance that covers the genetic testing that is being completed, especially when it alters medical management. So a majority of genetic testing is being covered when it is for medical reasons and when it meets criteria. So my insurance company will drop me if I test positive, and that is not allowed by many group health insurance plans. And we have really good coverage in the state of Wisconsin regarding group health insurance, which does not allow our most group health insurance companies to drop somebody if they have a specific genetic condition. Insurance companies are not allowed to increase the premiums for a single individual unless they increase it for the whole group. And we've always had good protections for a long time regarding group health plans in Wisconsin. And now we also have federal protections on top of that. So we have a lot of protections. Disability insurance and life insurance are very different. We don't really have protections related to those. So testing may not be right for everybody, and genetic counselors can help a person or a family understand what are the issues related to hereditary cancer testing and will I benefit from this. When there are characteristics of a hereditary cancer syndrome in a family, get the facts from somebody with expertise and then make a decision about testing. Just because you go to see somebody for genetic counseling doesn't mean that you will wind up having the hereditary cancer testing, but just understand the facts and then make a decision. So genetic testing misconceptions include the fact that people think that once a genetic test is done, that they're done for life. And that's just not the case. So like I said, in the old days and before 2013, related to breast cancer, we were only testing for 2 genes. So anybody that had testing done before then, and certainly even since then, probably qualifies for update breast cancer testing. But testing changes all the time. So if you had testing done a long time ago, certainly you can contact your genetic counselor and ask them if update testing is warranted for you. So people also ask, I had tumor genetic testing done, so do I need to have hereditary cancer testing? And the answer is that you might, because tumor testing and hereditary cancer testing are very, very different. Tumor genetic tests don't give us the same information that you would get from a hereditary cancer test. So here's some more common misconceptions. So the most important thing is the presence of many people with breast or colon cancer in the family. Not true. Age of onset is the most important thing when evaluating a family history, especially for breast and colon cancer. And regarding breast cancer and common misconceptions about family history, cancer on my dad's side of the family is not important. And I hope that everybody knows now that we inherit genes both from mom and from dad, and both sides are important, not just mom's. Half of all people with hereditary cancer inherit from their fathers. So I tried to highlight lots of important information about hereditary cancer conditions. And if you have any questions, I'd be happy to answer them. My email address is here, and feel free to reach out to me. But thank you so much. And I really appreciate, Dean, you asking me to present today. And do you have any questions, Dean? And I do see some things in the chat here, so let's see. Okay, thank you. No, I don't see any questions in the chat. And what else? Anything else, Dean?
My question is, are you seeing greater numbers of people taking advantage of genetic counseling than past years?
Yes. So we get referrals every day. We have a lot of referrals, and we have a hard time keeping up, actually. And there's been a huge growth in hereditary cancer testing. And that's because it's medically indicated for growing number of people. So if anybody has ovarian cancer of the most common type, people that are young with breast cancer, and I could keep going, many types of prostate cancer. So yes, definitely growing.
Okay, and then Hannah has a question in the chat. Did you see that?
Yes, I do. Okay. Let's see. What is the wait time to see a genetic counselor for something like this? Hannah, good question. So this is how it works in our clinic, and every clinic would have a different answer for this. So in our clinic, we will receive a referral and then we triage it. So if it's a person who needs information about genetic testing right away because they need it for surgical decision making, then we're going to triage it urgent, and then that person would get seen within 1 or 2 weeks, probably 1 week. If it's a person who is going to be getting radiation treatment and it's okay if we don't get the results right away, or if they're going to be getting chemotherapy first, then we would triage it potentially maybe 2 or 3 months, out, because they don't need that information right away. And if it's because of a family history and that it's not medically urgent at that moment, then usually we'll triage it maybe like a few months further out. And that's only because we don't have enough genetic counselors in our clinic right now. If we were fully staffed, those wait times wouldn't be as long. So really, answer is different for every clinic, I bet.
Great. Are there any other questions? Well, hearing none, then I just want to say once again, Sumedha, thank you so much for your presentation. And for those who are watching this presentation from the recording, I just want to remind you that there's also 3 other presentations, part of the series. Cancer in the Environment is the first one, and then Advances in Prevention and Early Detection or Detection of Breast Cancer is the second one. And Sumedha's is the third, and then the last one is Treatment Options for Advanced Breast Cancer and Research-Based Innovative Therapies. So be sure to check into those. And again, Sumedha, thank you very much.